Okay. Hi, everybody. Hi, Rondi. How are you?
Hello, doing great.
We're having some technical difficulties in our office today. We
No
usually
problem.
convene in our office, and it's going to be entirely Zoom.
I don't know why it's doing
There are going to be a couple more people that are going to pop in
Sounds good.
as we slowly figure out all of our technical issues.
Totally okay.
And Ray and I were on two different meetings or other meetings, and so only a minute.
Just another day.
Yeah. So thank you for making time.
Yeah, of course.
I'm just going to give it another minute, and then we'll get started.
Yeah. Sounds great.
We'll
Rondi, I forgot to ask you, you coming to the leadership advocacy meeting?
I'm not. I'm actually going to be in San Diego for the Surgical Education Week, running a panel that I've had trouble filling because half of my invited speakers were going to be in DC.
Bad timing.
Yeah, that's all right.
All right. Well, I'll introduce Dr. Kauffman, who is he was a surgical oncologist at Vanderbilt and associate program director of the general surgery residency and the inaugural vice chair for global surgery at Vanderbilt. Dr. Kauffman actually, she and I have met almost monthly for the last 5 months for one reason or the other at various conferences across the planet. So we've kind of become like partners in this journey by great chance. But it's been a great opportunity to have some time with her and hear about some of the phenomenal work that she has been doing that really I think has to be done. And I hope that some of her work can even teach us lessons here in the state of Utah. And I'm hoping that this is part of the reason to have Juan Carlos on, is that it would be great to have Dr. Kauffman here at the University of Utah and even meeting with our state legislature to kind of help us figure out how we can replicate some of her amazing work that she's done in the state of Tennessee. And Ray Price is trying to do the same thing with having her work with the American College of Surgeons to see how we can do it at the federal level. So that's the kind of work that she does in her free time when she's not a cancer surgeon and mom of multiple kids. So with that, I will turn over to Dr. Kauffman. So welcome.
Okay. Thank you. I'm going to share my screen. Is that showing up for y'all?
Yep. Perfect.
Okay. Well, thank you so much. This is really an honor and so much fun to see familiar faces from various walks of my life sort of interceding in one series of Zoom faces. So this is really fun. And despite this perhaps seeming that everything was very linear in its course, and Sudha's very gracious introduction, I will tell you that I did not start out in global surgery or medicine having any intention of being involved in advocacy. I think it's my civic duty to vote, but that's kind of where it ended for me until various things in life sort of put me in a place where I felt like I had to act because I was in a position where I could. So let me try to advance my screen. There we go. So I don't have any commercial or financial disclosures, but I'm very passionate about global surgery and this topic in particular. So that is definitely a disclosure. So I'm going to kind of try to go through this in a somewhat sequential way, but just talking about the landscape of global surgery as it relates to bidirectional exchange, why I have come to the conclusion that policy change is really important in moving the needle in that regard. And then a little kind of a status update of where we are in Tennessee, but then also, as Sudha alluded to, at the federal level. So first, just kind of going through the landscape. This audience knows as well as any audience how academic global surgery as a field of inquiry and involvement on the part of academic institutions has really grown exponentially over the course of the last 5 to 10 years. There's a lot of interest in this from medical students to faculty. It's estimated that more than half of the general surgery residency training programs within this country have some sort of global rotation or global experience for their trainees. And these partnerships really take many forms, from the short-term kind of mission type of model that might be just for a few weeks at a time, to different locations over time, all the way to what I think we are more familiar with in this audience, which is this academic institutional twinning model, where institutions in a high resource setting partner with one in a low or middle income country setting, really for the long haul. So a sustained commitment over time to build capacity in clinical education, clinical care, research, et cetera. And there's a number of examples that are fairly well known. Vanderbilt is just one of several, but the University of Washington in Ghana, Memorial Sloan Kettering with their oncology initiatives in Nigeria, and then of course ACS and COSEXA partnering in Ethiopia and now expanding that into Zambia and other places. So Vanderbilt is really where my journey started in the academic global surgery world. And we have been partnering with Kajabe Hospital in Kenya since 2011. Our anesthesia group was there about 3 years before surgery was there, but we have had a very long-standing institutional commitment to that particular hospital. And we began funding a PGY3 rotation in 2011 for general surgery residents. Every one of our categorical residents can rotate in Kenya. It's fully funded. We've never sent all 8, but we've sent 6 at a time, or not at a time, but in a year. So this has been a very well-received and very popular experience. In addition to general surgery, we send anesthesia residents, OB residents, ENT, plastics, orthopedic surgery just started their program, and we're starting a urology program there next year. And this was then the subject of a study looking at the benefits of that experience on our graduates, the graduates from our training program. And the residents, or the graduates rather, across the board really reported a lot of benefits that they got from this time. They saw disease pathology that they don't often encounter in the United States. They had autonomy that was really contributed significantly to their education. So a lot of value in having a resident from a high income setting or high resource setting spend time elsewhere. But recognizing that these experiences are very unidirectional, we set out to really inquire of our host faculty and trainees what their perception was of these visiting faculty, visiting residents who would come for a period of time and then leave. And so we did a semi-structured qualitative analysis. We interviewed 43 faculty, trainees, residents at Kajabe Hospital, really with the question of what has worked, what hasn't worked, and if you were to ask for something that we could build together, what would you ask to make this relationship, this partnership, more equitable and better for you? So, as I mentioned, there were 43 people who participated in Kajabe, and that included 11 surgical faculty, 19 surgical trainees, which are like residents, 11 medical officers, 1 clinical officer, and 1 intern. And this, as many qualitative studies, takes quite a bit of time. And the reason that it does is because you really want to, without suggesting things, you want to develop or hear the themes that come out over and over and over from these interviews. And it pretty quickly became apparent that by and large, our hosts really felt that this was beneficial. There were a lot of things that they got out of this experience that they thought helped their program. Some of that was the ability to learn from residents and faculty who may have expertise in areas that were different from their own. They felt that it built their capacity in skills, clinical skills, but also in research. They also gained broader perspectives about healthcare around the world, and they felt that it improved their work ethic to integrate with teams and trainees and faculty from other places. But as you might expect, not everything was all roses. And so there were some very specific things that came out over and over that were challenges of these visiting experiences. And that included, they're here for a short while and then they leave. Some visitors did not integrate well into the system, which you might not be surprised by. Cultural differences were sometimes very much a barrier to integration, and sometimes even led to really what they perceived to be problematic behaviors on the part of the visitors that were disrespectful or perhaps actually impeded patient care. But about half of them, without being prompted, specifically mentioned that it was imbalanced, that this relationship, while had a lot of benefits on both sides, it really kind of was imbalanced because they could not come to our institution or didn't and participate in a similar experience. So that really led me to start asking some questions about why that hadn't happened in 11 years, why we had never hosted one of their trainees at Vanderbilt. And there are a number of barriers to such exchanges. And I'm not talking about someone coming and watching what we do, observing what we do, but actually participating and being a part of the clinical care team, which is what our residents do when we go there. And this paper really nicely outlined some of those barriers. And I think there's really three main ones to consider. So one is how licensing is done in this country, and specifically medical licensing. That is managed at the state level. So each individual state and their medical board has authority to define what medical licenses they will give, when someone might qualify to be exempted from a license, and all of the guidelines around those licenses. The other issue is visas. So if you're going to come into this country, you have to have permission to do so. And there's really very limited availability of visas. Now, you can obtain perhaps a J1 visa for purposes of participating in or enrolling in an accredited training program. But that requires taking and passing all 3 steps of the USMLE boards, which is costly and very time intensive, and might make sense for someone who's going to do a residency program or a fellowship. But if you want to spend, I don't know, 1 month or 3 months doing a rotation, it doesn't, that doesn't make sense to go through that effort to do so. And then the third thing is medical liability. So how do we address malpractice? How do we address risk at the level of the institution? And so I started with kind of the tenet that there's some barriers, there's some challenges for sure, but there's some really important reasons to take this up. And that would include supporting international goals for health. So, the global health is far more intertwined than I think maybe we recognized even a couple of years ago, but I don't think we no longer have the luxury of assuming that the diseases that someone on the other side of the world is up against isn't or can't affect our own community. These bidirectional medical exchanges, I would say, really also improve the long-term stability of global health training. So as people move across country borders for all sorts of reasons, refugees or moving for work or whatever, they bring risk factors for diseases that may not be familiar to the place that they move. And it's really important for clinicians around the world to be familiar with the medical conditions that affect our neighbors in Sub-Saharan Africa or South America, because they may be in our community next year. So I think that's part of stability in global health. And then it really strengthens health systems. I mean, disease knows no borders. And so having the ability to really mingle and in a equitable, bidirectional way, exchange medical knowledge and skill, I think really benefits all of us. So where are we now? So I started in Tennessee, where I live. And after understanding some of these barriers, I started making some calls, and I picked up the phone. Well, first I Googled, and I looked through all of the licenses that the state of Tennessee offers. And there's 8 or 9 of them. And you look through all the details of who can apply, what the requirements are, what it can be used for, and what it cannot be used for. And I didn't see anything that fit what I needed. And so then I made a phone call to the director of the Tennessee Medical Board, and we went through all the different licenses. I told her what I wanted to do and why. And she said, that sounds like a really good idea. I don't think we have anything that fits, but let me have you talk to our legal counsel. So then I talked to the legal counsel, and that was a really important conversation, because not only did they confirm that there was no existing pathway to bring someone from overseas to an institution in Tennessee for a short-term clinical. I also learned that the ability to do that, or the ability to make a new licensure category, didn't rest with the Tennessee Medical Board. In fact, that was something that in Tennessee had to go through the state legislature. And so if I was going to change this, it would actually require a new law. So we wrote a law. We wrote a proposal for a law. And in that proposal, I think there were a couple of things that were important for ultimately being successful. So first, we laid out why we thought this mattered, why it is that our legislators should care, and why this is something that is good to do. And then anticipating some of the potential concerns that would arise, such as risk, such as cost, what's it going to cost the state? We included, or we addressed some of those things in our proposal. So we proposed that foreign medical graduates would need to be supervised. We didn't define direct, indirect, et cetera, but they needed to be supervised by a licensed physician, similar to what a resident would do. They could participate in all aspects of patient care, painting a history, doing an exam, scrubbing into procedures. We did limit their ability to prescribe medications, because that brings a whole nother level of complexity when you're talking about DEA numbers and all of that. And really, I don't think that's necessary for the clinical training we're talking about. They did have to have some proof of malpractice coverage, which was just as much for their protection as ours. There has to be a host institution. So some institution who says, yeah, we're going to have this person come and work at our institution under the supervision of X person. And then we also limited the licensure to 90 days, specifically because we didn't want this to be a pathway for people to come here and then stay here. So we really wanted it to build capacity, but not to be a permanent solution to fix our shortages in rural Tennessee, for example. And then we were very explicit that this was a no-risk burden financially to the state. So, they're not having to put in funding, et cetera, for this. So we dubbed it the Visiting Fellows Act, and then secured a sponsor in the House and the Senate. It helps that we have a few physicians in those legislative bodies, and they were actually very helpful and very receptive in sponsoring this bill. We talked to the director of the State Medical Board again to make sure that they were on board and they were supportive of this. Most academic institutions have some type of advocacy office that needs to be informed of any state level advocacy that you're doing. And so we were sure to loop them in, make sure that we were not working against their current initiatives, and kind of kept them up to speed so that they could mention this as they were talking to the legislators that they were meeting with. And then went through the process of testifying to several different committees within the legislature. A number of faculty and residents wrote letters, made phone calls just to voice support for this initiative, which I think was also really helpful, because the medical community has a powerful voice. So this passed the House of Representatives, actually surprisingly easily, as well as the Senate, and then was signed by the governor in the summer of 2022. So at this point, the law has now been passed, and then that law directs the medical board to write the rules and regulations that will govern the new licensure category. So it's now been assigned to several members of the medical board who are working with their chief legal counsel to actually write the licensure rules. And they are anticipating that the license will be open to application in the summer of 2023. So this kind of lays out, just in summary form, the steps that we took to, at least within Tennessee, get this passed through our legislature. So we are now the 7th state. There are 6 other states that have some form of licensure for foreign medical graduates. Now, I should specify that some of these, Massachusetts, for example, are limited to faculty. You have to be a senior faculty who has some type of expertise that is particularly beneficial to the state of Massachusetts. So it's not a trainee experience. But they have recognized that foreign medical graduates bring expertise that is useful. The other state that is closest to Tennessee is Ohio. So they actually have a specific training license for foreign medical graduates that we actually modeled our proposal to be very similar to what Ohio had proposed and passed. So then that brings us to the second topic, and that's the federal visa advocacy. So I've mentioned that the J1 visa category is not designed, and in fact, you really could not use it for short-term purposes. There is an H1B visa category, but the issue with that is that there are very, very limited numbers of H1B visas, and so would not really work for this type of program. And so that's really the next hurdle. So we have started already working on on federal advocacy, and kind of where we are at this point. So first I contacted the authors of that paper. Because they started the discussion, so I thought they might be able to help continue it. And in fact, they are extremely interested and have been very active in working with us to reignite this advocacy. ACS Operation Hope, the advocacy committee, has been very active in voicing their support and in really working now in what I would say is a coalition to bring a proposal forward that would create a subcategory for a short-term J1 visa. The ACS has lobbyists, as many national organizations do, that have been very involved. The Consortium of Universities of Global Health also, and their president, Keith Martin, and then a number of other national organizations. ACOG has expressed some interest, the AAP. So some of these other organizations that have programs for their trainees are also very interested in seeing this be passed. So, once you kind of have your working group, you have to figure out who your audience is, and that has taken a little bit of doing, but I think that we have made a bit of headway in that. So somewhat similar to the story in Tennessee, if you're going to create a new visa category, that requires an act of Congress. But if you are going to amend the language in an existing visa category, i.e. a J1, to create or to change the vocab or the wording so that short-term experiences without taking USMLE are allowed, that goes through the Department of State. So we have a number of contacts within the Department of State who are very excited about this and have expressed that there's really, I think, a good atmosphere within the Department of State to address this right now. So I'm taking that to be a bit of encouragement, since I don't think it's always been the case. But so we're now working with the Department of State to identify which person or people within that organization actually make decisions about these things. And then the ACS Hope Advocacy Group has started writing a statement of support, so a mission statement with supporting documents, and then really a draft of what the ask is, so that we can then take that to the lobbyists, but also ultimately to the Department of State to make a decision about enacting that. So I'm going to stop for a second there. I have a lot that I could still talk about, and I could probably talk all evening, but I'm going to stop and just maybe open up the floor for some discussion and questions and ideas, and hear from you a little bit.
Yeah, thank you so much, Dr. Kauffman, for that fantastic talk that took us from surgery all the way to making congressional laws or federal laws. So incredible amount of work. I have a number of questions, and we have a wide variety of staff, trainees, faculty, colleagues, students on the call, and I'm sure they will have a variety of questions. Some of the questions I have are both simple. I have simple questions and complex questions. Let me ask you some of them, and you can kind of go through. This is an enormous amount of work and an amazing potential for impact. What is the timeline that it took you to accomplish this, getting this law passed? How long did you have to work on this? And then a couple of detailed questions. When you say trainees have to come in with malpractice coverage, what would that? How does that work? What would that look like? And you kind of alluded to this. You said foreign medical grads, non-faculty trainees. Do you mean medical students, residents, fellows, and inclusive of faculty? Who is the audience that would be interested in this? So those are sort of the questions I have to start.
Yep. So first, the timeline. So I will say I had a little bit of experience with advocacy a couple of years ago. So I came in with a little bit of an understanding of what that legislative process looks like, which helped. But in terms of timeline, I mean, I wrote the proposal in late January 2022, and then we spent basically most of February of 2022, which is when the legislative session is really kind of at its peak, meeting with various representatives and congressmen and women, and going through the committee process. But then it was voted on by the Senate and the House in April, and then signed by the governor in June. So it was 6 months, but it was helped along by the fact that I'd had some experience with our legislature prior to that. And then the second question you had was about malpractice. And I think that is not an insignificant issue. So really, in going through conversations with our risk management and our executive board, there's a couple of strategies. One is you can purchase malpractice for short periods of time on the free market. Locum tenens docs do it. It's not cheap. That's the biggest problem with that particular strategy, but is an option. At Vanderbilt, as many institutions, we are self-insured by the Vanderbilt Trust. And you have to be covered by the Vanderbilt Trust. You have to be considered an employee of Vanderbilt. So my current discussions are with a number of individuals in our medical executive board to say, well, we as an institution or a department of surgery have already recognized that if we're going to really make a program like this work, we're going to have some funding to help our partners in Kenya with the costs associated with spending a month in Nashville. Spending a month in Kenya is, about a third of the cost of what it would be for them to spend a month in Nashville. So we as a section of surgical sciences have already committed to raising funds or to establishing a fund specifically for this bidirectional exchange. So my ask to the executive board is, okay, well, if we're already going to be providing some funds, let's say a housing stipend, can we just pay them that so that they're considered employees and then they would be covered? And so that's the executive medical board has yet to give me an answer on that, but those are the discussions of the last couple of weeks to get around having to spend a large amount of money purchasing malpractice insurance on the free market. I know there is a program that is a one-year fellowship in the Midwest for orthopedic surgeons from Central America, and that's how they do it. The group just includes them. They pay them a small stipend. They're considered employees, and then their malpractice is covered under that. So I think at least in our situation, that's the ideal strategy. I have a feeling that that's going to be an issue that institutions have to work out kind of at the institutional level, because it might differ from one setting to another based on how the malpractice coverage is provided. And then you asked about FMGs. So yeah, I used that very broad term and was not explicit with it, but in our proposal that included residents. So trainees, we in our proposal said they had to have completed medical school training. So we were not intending for this to be used for medical students, but for residents, faculty, also people who maybe are in practice, have completed residency training in their region, but maybe they want to come and do a month of learning laparoscopy or something that they have not had, specific training in.
Fantastic. I just want to again say that it's just unheard of, at least to me, to both create the concept of a bill, write it up, get the right champions to pass it across House and Senate, and have the governor sign it within 6 months. It's absolutely just unbelievable amount of work for an individual in the United States. So Dr. Kauffman, just amazed at the work that you've done. So I just wanted to recognize that. Let me go around the room now and see what other questions there are. Dr. Dominguez was our visiting global surgery faculty scholar the last week from Cali, Colombia, and that's on his way back to Cali and going through JFK, and would be very interested in this kind of a thing, because that's how I met him. I met him when he was an observer at another institution where he had come to kind of gain additional set of skills. So Dr. Dominguez, do you have a question for Dr. Kauffman?
Well, hello, everybody.
Hello.
As Suda said before, I was spending the last week in Utah healthcare systems, and I really spent a really wonderful time. The same hello from the New York City right now, because I got my travel back home tomorrow. I am really interested in this point because it's been several years since we were maybe in my country or in Latin America waiting for this kind of opportunities for us and even for our trainees. We should be really interested in that, create like an invitation to enhance the partnerships between us there, where we got some experience, and maybe things that you get less experience, like trauma issues and how we deal with something in surgery in low-income countries. The only question that I have is how to deal with maybe the insurance company associated with the things like malpractice or things like that. I got some experience working with surgeons from the United States or Europe with us. How we avoid these kind of things in our country is he can be involved in the cases, can be involved in the decisions, but if you don't use the name in the paper records, you don't. It's like that person is learning. The person is like our residents. They're always with us. They share their opinion. They can make physical examination. They can create I don't know, they can suggest exams and whatever. But the responsibility or the medical responsibility is only for us, for the faculty. I was wondering if maybe if you use this kind of models can create a better way, avoiding the necessity of get that name, because that person is only there for learning. It's not for making a medical decision. Even for me, I speak some English, and maybe the communication, even for Americans, sometimes it's difficult when somebody is from, there or other places. I was wondering if maybe you can think a little bit about it. I invite you, all of you, to share some time with us in Colombia. I am part of a level 1 trauma center in Cali. The name of the clinic is in Banaco. We are a joint commission center. We got different scenarios where you can create or where you can learn many things. You're more than invited. I'm short in words right now to express the importance of these kind of meetings, you know.
Thank you.
That's it. Mhm.
Yeah, thank you, Dr. Dominguez. Yes, I think you're exactly right. That's exactly what Dr. Kauffman is trying to do, is to work out how to staff, create the right role so that the malpractice can be covered through some degree of employment. And that's part of the reason why here at the University of Utah, we try to create these different scholar and fellow roles, because it won't take very long to kind of then attach a small stipend to them, and then to have the person be employed, and then potentially have more access to more resources here. So yeah, I think we have a lot to learn, and appreciate your comment, Dr. Dominguez. Let's move on to Juan Carlos.
Hi, good afternoon. Thank you, Sudha. Dr. Kauffman, it's a pleasure to see you again. It's my lucky week, I guess. Thank you again for a wonderful presentation and for your willingness to share so freely. This is fantastic. Like, I really have perhaps just a corollary questions to both Dr. Jayaramans and the comment from Dr. Dominguez. One, you mentioned something that I found really interesting, and it's the ability eventually to have one of the visitors considered at least temporarily as an employee. That I think is a quite creative approach, and I had a question regarding that specific point, which is managing the issues of appropriate credentialing for an employee. That is something that would get on the way just because the individuals are not necessarily have not homologated their education in the country. That is one question. And the second question is a bit unrelated, but it is related to your exercise. When you were presenting your cases, I mean, going through the list of states, you mentioned also when we met that Ohio was kind of the guiding star in a point. In the conversation you had with your legislature, how important was the reference to other states already moving forward in this direction?
Yeah. So first, credentialing. I think that is definitely an important point, because again, institutions are going to do credentialing a little bit differently. And at least in our state, we have a lot of trainees who are various levels of completion of their training. And they can be exempted from having to, they can even be exempted from having to have a state license. Our residents don't even have to have licenses because they're considered in a training program. For this program, we had to create a new license because they're not going to be enrolled in a full training program. But because we had stipulated that these individuals are going to be supervised, they're essentially working under the credentialing of their supervising faculty member. So they don't have to have their own credentialing. Our credentialing office doesn't have to go through and individually verify that they can participate in X, Y, or Z procedure, but that's really why they have to have a designated supervising faculty member. And then your other question was about Ohio. So it actually, I think, was important for our legislators to know that there was precedent for this. And I think it also, it helps to appeal a little bit to pride. Tennessee was still kind of leading the way, but they weren't the first. And I think it gives them a little, we're a kind of risk averse state. And I think, if I had said, if we were to be the first ones, it would have been harder to convince them, but someone else had already done it. And yet it was really, I think, nice for the legislators to hear that, this was something that Tennessee was really poised to lead the country in, because there's states that have done this. And so I think it was helpful for them to hear that. And it's also been helpful for the Tennessee Medical Board is they've been starting to write the rules to be able to review what other states have done, specifically Ohio, because, you know, that's helped, I think, guide how they write those rules, what the guardrails are, what things need to be considered. And so they've certainly utilized those resources as they've been writing the rules for our licensure.
Thank you.
Dr. Kauffman, just to follow up on that point of Ohio, do you have any sense of what the experience has been in Ohio? Have there been any challenges, or what lessons are there to take from that? And after you answer that, I'll go to our conference room for Ray Price and
Yeah. So, you know, it's interesting because I was actually talking with Dr. Negrete on Monday about this, and I haven't spoken to many people in Ohio. I have spoken to a few, and they have not utilized that licensure category as much as I think they had anticipated, and some of that has gotten back to funding. You know, having just the cost associated with someone coming here has been difficult to has kind of naturally limited how many individuals could participate. So their license has been on the books since like 2012, but they haven't had as much ability to utilize it. And then, of course, with COVID shutting things down for a couple of years, sort of about at the point that you'd be gaining a little bit of momentum. And then I think that kind of stalled it out a bit. But
great, thank you for that. Dr. Price, do you have a question, or Leaf?
You know, I mean, when they the Ohio group presented their material at CUGH just after 2012, and they highlighted this passage, but then they also spoke about the challenges they had of trying to actually use it, both financially as well as, I think, still malpractice was a problem for them. And so even though that they got a law passed, trying to meet with the restrictions that are still even within that law was extremely difficult. And so those are some barriers. One of my other comments was, you can use my example. The University of Utah actually hires me for 1 cent a year. So you don't have to have a whole lot of money to become a faculty person.
that's perfect.
I just got the the W4, W2 thing the other day or whatever. It says 1 cent is what they hire me.
I don't know that I want to suggest that to my chair. I might give him some ideas.
I just want to know what the taxes are on that 1 cent, right?
Yeah, it probably costs more for the paperwork.
For sure.
So anyway, I just wanted to, again, just to echo what a phenomenal amount of work. And I think what's exciting is Ohio really was the first. And now these other states, and as we've talked, Rondi, I think that's a multi-pronged approach that we need to move forward with, is a state level, a national level, federal level, and even the local level. And all those, and I think you've done a fantastic job of showing us specifically with the state and local what can be done, and maybe that's one of the things that we need to work on to get that passed here, to join that group as we try to fight this federal program. So anyway, I just want to tell you, wonderful work, and I love your slides there. So
thank you.
Other questions or comments from other members of the audience?
Yeah, I got a comment and question for Dr. Kauffman.
Okay.
Yes.
Most about here, I'm not a surgeon. I'm clinical neuroscientist, specialty in neuro rehab.
Great.
And I'm very interested in what you have to say today, because we went through this similar process in trying to establish the first neuro rehab clinic in Morocco, North Africa. And we sent a lot of physiatrists and therapists to Morocco to help us with the training and some kind of basic medical education. And between 2014 and 2019, we did an exchange program that's involved about 20 teams. So it's a lot of traveling. And my take from that program is that we got a bigger bang of dollars, so to speak, by sending people from here to Morocco instead of bringing them people from Morocco to here. And for the same reason that you you cited visa issues, cost of living, the HIPAA rules that prevent the Moroccans from basically interacting with the patients here. So my question for you is, do you still believe this two-way exchange has to be 50-50, or do you think, like we discovered in our own experience, that it may be better to focus on training the people on their own environment, like in Kenya, which also, by the way, will prevent what you mentioned, which is a very important thing, brain drainage.
Yeah, thank you for that question. I think it's a really, really good point. So, I think so first, I think your last comment, I'm going to start with your last comment, because I think that's really important. The idea of training a practitioner for the location that they're going to practice, I think is really the ideal place and model for training. I still think that there is value in bidirectionality, but how much that split is might differ from one place, one region, one institution to another. I don't think it'll be 50-50 between our partnership, probably. But what I think is important is first to give the partnering institution, our hosts in Kenya, first of all, a voice to hear what their needs are, because I'm not in the best position to know what their needs are, but they are in a perfect position to tell me what their needs are. And they do have some very specific needs that they have identified would be ideally approached with the ability to come here. And for very specific reasons, capacity building in a specific area, skill that they can't get at home. I can vouch that the surgeons and trainees in Kenya could operate circles around me. I mean, they are so good. Their scope of practice is beyond mine. Their expertise in dealing with things with really limited resources humbles me every time I talk with them. But they don't have an example of a multidisciplinary cancer center. And that's something that they would really love to be able to spend some time learning from us. How do you set that up? And it's not just the time they're here, but then that also should include long-term relationship mentoring, being a resource for them as they then go back, take what they've learned here and apply it to their context, because it's still going to look different in their context than what it looks like here. But there may be skills or ideas or thoughts about how to set it up that they will get by being here that they will not get there. Maybe it's a trauma center, maybe it's laparoscopy. But I think, giving them an opportunity that if their needs would be better fulfilled by a short time here, I think that's valuable. At this, where we are at this moment, they don't even have that option. And I think giving them that option and that pathway empowers them to identify what their needs are and where they'll best be filled.
Thank you for joining us, Dr. Sabai. We look forward to your talk in another month or two about your work. I think Dr. Kauffman really appreciate that response of sort of customization. Any other comments? Dr. Rockwell, do you have any comments? So Dr. Rockwell is one of our plastic surgery faculty, and he has helped with setting up several different fellowships, both short and long-term in Ghana, related to hand surgery, with breast cancer surgery. He's now been asked to see if he can help with creating a curriculum for a burn surgery fellowship. We're also in the process of working with the Ghanaians on a colorectal surgery fellowship, with the thought process of having some training here in the US and some training in Ghana. But of course, the US component of training is not hands-on, right? Because we don't have these kinds of laws. But I wonder if Dr. Rockwell, if you have any comments on this experience.
Oh, it's very interesting to hear. And it's a real point that the Ghanaian medical students can come here and scrub in and do everything just like our med students. But when their faculty members come, they can't touch a patient. And that's, I think, especially their culture, that's very hard for them to accept, that a student can do much more than one of their attendings can do. But it's very interesting. I was just thinking there's a retired plastic surgeon here who was president of the Utah Medical Association. And I was thinking I should contact him and see what suggestions he would have for getting a comparable law in Utah. But no, very, very, very interesting talk. Thank you.
I think it would be great to invite Dr. Kauffman to come and present to us across departments at the School of Medicine, and then potentially even across the university, across, you know, even the non-clinical departments, to see how we can kind of mobilize our community to create something like this here. Our Department of, what is it called, professional licensing, DOPL, in the state of Utah does have some mechanisms for trained faculty, and actually this is something, Dr. Ruckel, we can review together, for trained faculty to come here if they are appointed in a certain manner. But they have to be, I think, have had 5 years of work experience or something along those lines, but not trainees. And so that's where there's gaps. So we can currently figure out how to get medical students here and how to get trained faculty here, but we can't actually do that for trainees. And so there is a gap that could potentially fill a natural area. But I think we could, if we could mobilize across departments at the university and maybe even across institutions here, with even IMC, there may be some potential to really be able to push on the legislature. The other thing I was thinking of is, so this week, on a sort of semi-related note, this week I'm on service for trauma and acute care surgery. I'm on a team that doesn't have any trainees. I'm on a physician assistant and nurse practitioner team. So when I have to go to somebody who's been in a gunshot, who's been shot, like the only people who assist me are PAs and Ps, which is fine. But I wonder if an opportunity like this would allow us to kind of backfill those kinds of teams that we have. Because at the University of Utah, there are quite a few teams that are non-resident based because we're short-staffed. We don't have enough residents. And I wonder if even having a mid-career resident or a senior resident here for a couple of months at a time would allow us to backfill that and have more staff. I don't know if in plastic surgery, if that's an issue, or Ray, I don't know if that's an issue as much at IMC, but I'm wondering if there are other kind of short-term staffing benefits that could be used as a carrot to get our different departments and institutions and organizations to buy into this concept. Thoughts, comments on that?
Yeah, plastic surgery would be in the same situation, and we don't have PAs, but there are times where it's an intern that's assigned when there's not a resident available.
Yeah, so I think maybe it's just a matter of kind of figuring out our own strategy for the state of Utah of how this could work, while the federal strategy is in progress. Because as someone else has mentioned, this is a state-by-state system. And so we need to kind of think about our strategy at home. That being said, last few minutes of the hour, does anybody else have any other last comments or thoughts or suggestions for Dr. Kauffman?
We should stay in touch,
Yes. Oh, yes. Don't worry. Dr. Kauffman and I
Yes.
talk almost monthly. So we've been at conferences almost monthly for the last 5 months. So we're practically related at this point. So yeah, well, thank you very much, Dr. Kauffman. And I'd like to also just tell the audience that, there's a concept called laboratories of democracy that the Supreme Court justices have written about in the US. Each of the 50 states coming up with different ideas that can work or cannot work, and that states learn across. And there's actually a great political book that I read recently called Laboratories of Autocracy, with Ohio being the emblematic state that does a really poor job. So it's fantastic to hear that Ohio is doing something well. But you know, to kind of understand how law gets made, if you're interested, that's a great book to read. It's very sobering. But otherwise, I think if we're all done with questions, thank you so much, Dr. Kauffman. Thanks
Yeah, it was my pleasure.
for participating, and see you next time.
Thank
All
you.
right. Bye.
Thank you.
Bye, everybody.
Thank you,
See
bye.
in Colombia.
Thank you. Excellent talk.